Good morning, everyone. First up, we have a University of Alabama Division I women's rowing champion, who then went on to get a master's of medical sciences, and is currently a medical student at Nova Southeastern University. She is a native of Florida. Her areas of greatest interest include urogynecology, reconstructive pelvic surgery, and genitourinary reconstruction. She also has a dachshund named Autumn. Please welcome Emelia Watts, who is presenting ketamine-induced uropathy, what it is and what we can do about it.
Thank you, Soam. So as he said, my name is Emelia Watts. I am a visiting student from South Florida, NSUMD, and I'm going to be talking about ketamine uropathy today. So these are my LOs. Understand the basic pathophysiology of ketamine uropathy, recognize management of this pathology in urology, including its pharmacologic and surgical options, and to explore the expanding uses of ketamine in medicine and the implications for a urology practice. So we're going to start with a case report. So this is a 27-year-old female with no previous medical history who was initially presenting for severe LUTs, occasional urge incontinence, sense of incomplete emptying, dysuria, and dark-colored urine. So on UA, she was positive for red blood cells and white blood cells, but her urine was non-infected. Of note, in her social history, she does have significant recreational drug use, primarily ketamine, LSD, and MDMA. And she did actually work as a DJ, so was very commonly in the club party scene. On urodynamics, she expressed first desire at 75 milliliters and was unable to tolerate greater than 125 milliliters. On flexible cystoscopy done in office, you can see the results here, but severe inflammation of the bladder wall was seen with edema, erythema, and areas of transmural necrosis and ulceration. And I think I might have spoiled the ending, but she did have ketamine-induced uropathy. So what is ketamine? How does it work? Why do we use it? So it is a dissociative anesthetic that non-competitively antagonizes NMDA receptors. And it's very attractive anesthetic because it causes conscious sedation while maintaining a high heart rate, cardiac output, blood pressure, and cerebral blood flow. It also causes bronchodilation and as such can be used for refractory status asthmaticus, as well as most recently is approved for treatment-resistant depression. So just a brief overview of ketamine uropathy. It's often called ketamine bladder, but it really does affect the entire genitourinary system. So symptoms typically first start with LUTs that can be pretty severe, sometimes 30 times a day, using the restroom, really small voids. They end up with a diminished bladder capacity, pelvic pain. A lot of the patients end up with hydronephrosis and can also end up with ureteric strictures. So it'll cause a fibrotic, thick-walled bladder with that is typically hypersensitive and hypercontractile. And there is significant demographic variation in this disease, as you can imagine. It was first described in Asia and Canada back in 2007, and it does show a higher prevalence in those countries as well as in Europe. And in any party city with a really large club scene, it tends to show up there as well. However, ketamine use is increasing in the US, and even before FDA approval for ketamine use for depression, it was already on the rise. So what does it look like on imaging? It's pretty impressive, as you can see. So this first, if you can see, yeah. So this first patient here is or was a 26-year-old patient So they had a contrast CT, which you can see a pretty shrunken bladder and very thick walled bladder here, and associated bilateral hydronephrosis. This patient here is 28 years old. Their CT also shows very thick walled bladder with hypervascular mucosa, and the hourglass appearance of the bladder, which can sometimes be associated with ketamine uropathy. And finally, here we have a CT urogram in a young patient who developed a distal complete ureteric stricture and became completely dependent on nephrostomy tubes. So very often the hydronephrosis that you see here is also associated with hydroureter due to bilateral ureteral reflux from a severely diminished bladder capacity. But as you can see here, it can also be due to upper tract disease, can also be due to stricture formation in this pathology. So how does it work? The exact pathophysiology is still yet to be elucidated, as it is a relatively new disease that we know about. But the proposed pathophysiology is that ketamine ions in the bladder wall will result in neurogenic and IgE-mediated inflammation, stimulation of the inducible nitric oxide synthase cytokine COX pathway, leading to persistent inflammation and fibrosis. Given the IgE-mediated nature of this disease, it typically will resemble eosinophilic cystitis more than an interstitial cystitis picture. And it leads to bladder barrier dysfunction with a denuded epithelium, impaired gag layer, and dysfunctional epithelial junctions, and as well as microvascular injury with ischemia, inflammation, and necrosis, and upregulated apoptosis. Of note, after one use of ketamine, I don't have it in front of me, but I believe it will stay in the urine metabolites for about 14 days. So one insult will continue to damage the bladder for a pretty significant amount of time. So how do we diagnose it? So you want to do a renal bladder ultrasound or a RUG to evaluate the upper tract, as I said before, it can really affect the upper tract. You'll do avoiding diary to kind of elucidate their the severity of their lower urinary tract symptoms, as well as urodynamics and cystoscopy. And these will usually reveal diffuser overactivity, poor bladder compliance, low capacity, and vesicoureteral reflux. Wu et al. In 2016 actually described the first clinical staging of ketamine-associated urinary dysfunction, which is in this chart here. So at stage 1, this is the least severe stage of ketamine uropathy. Typically, these patients have been using the drug for less than 2 years and are usually taking in less than half a gram of ketamine per week. And at this point, their labs are usually normal and imaging is pretty normal. And at this point, conservative treatment tends to be effective as long as they abstain. Then when we move into stage 2, these patients are typically having a bit of a heavier dose weekly, 0.5 to 2 grams, and typically have been using for over 2 years. And this is when you start to see abnormalities in liver labs, as well as you start to see the physical changes in the bladder. And you can have some abnormality in GFR. And at this point, conservative treatment may be useful, but typically, even at this stage, will not completely resolve the issue. And then stage 3, this is when we progress to end stage bladder. And these patients are typically using for over 4 years. Typically, they have been using pretty heavy doses, greater than 2 grams a week. And at this point, they're going to have abnormal labs in their renal and liver function, and you're going to see both lower and upper tract damage on imaging. And at this point, conservative treatment is really not going to do much for them. So what do we do about it? Oh, no, that's the next slide. Sturgis et al. Presented their experience with ketamine uropathy in a single use institution in the United Kingdom. So they had 81 patients with ketamine uropathy identified between 2011 and 2022. However, a large proportion presented from 2018 onward. They have seen a significantly increase in incidence of ketamine uropathy, and similar trends have been observed in the United States. Their therapeutic interventions included anticholinergic medication, cystodistension, and intravesical sodium hyaluronate. In their population, hydronephrosis was present in 24.7% of their patients, and 6 of the 81 patients required nephrostomy tubes. And 1 patient of theirs had to undergo bladder augmentation surgery. All right. So what does the upper tract involvement in ketamine uropathy look like? So Yi et al. Described their cohort of patients with ketamine-associated uropathy. They had 572 patients identified between 2011 and 2015 in Hong Kong. And 36% of these patients were abstinent at diagnosis, defined by greater than 4 weeks of abstinence at the time of study enrollment. So in table 1, you can see the patient demographics and univariate analysis from their study. So the mean age at diagnosis was 25.3. And 16.8% of these patients had hydronephrosis on ultrasonography. 9 of these patients required urinary diversion with a percutaneous nephrostomy drain, and 4 patients required double J stent insertion. There was spontaneous resolution of hydronephrosis seen in just 3 patients after a period of between 4 and 12 months of abstinence. However, interestingly, abstinence status and mean amount of ketamine consumed were not known to be significantly different between patients with or without hydronephrosis. So in table 2, we have their multivariate regression analyses for parameters of hydronephrosis, which found that age, decreased functional bladder capacity, elevated serum creatinine, and abnormal liver enzymes were found to be statistically significant predictors of hydronephrosis in ketamine uropathy. As I said, I think earlier, a lot of the hydronephrosis is due to reflux up to the upper tract due to the hypercontracted bladder. But when strictures do form, there isn't a specific place where they tend to form. They can form really anywhere from the UVJ to the UPJ. Additionally, almost half of the patients with severe cystitis in their cohort would have bilateral upper tract involvement, and there did not tend to be any correlation with the severity of their lower urinary tract symptoms. So what do we do about it? How do we treat it? So as with many drug-associated diseases, the first step is to encourage abstinence. While symptoms may improve with abstinence, just one relapse can send these patients back into a really severe disease state. So their care should be not only urologic, but addiction medicine, psychiatry, and social work often need to be involved. And pelvic floor therapy can be helpful as well. Pharmacologically, these are typically really only going to work for the first stage, but we can use NSAIDs and COX inhibitors, as well as neuropathic analgesics such as tramadol and gabapentin. steroids to calm down the inflammation, and anticholinergics like sulfenicin or beta-3 agonists like mirabegron. So when that fails, we can move on to intravesical treatments. So we can do bladder installations, such as sodium hyaluronate, hyaluronic acid, and chondroitin sulfate. We can do botulinum toxin or Botox injections into the bladder to decrease their OAB symptoms, cystodistension to try and increase their bladder capacity, or embolization if there's mucosal disruption, bleeding. When that fails, we move on to surgical treatments, which may include augmentation cystoplasty, partial cystectomy, cystectomy with urinary diversion, nephrostomy tubes, or ureteral reconstruction. So when reconstruction is required, it can be pretty morbid for these patients. So Vizgen et al. Just put together a narrative review, including 23 patients or 23 papers, which comprised 875 patients, 22% of which underwent reconstructive surgery. And they saw an apparent rapid progression from the beginning stages of ketamine uropathy to end-stage bladder, with just a 1-year difference of ketamine abuse between those patients who required surgery, typically 4.4 years of use, versus those who did not, just 3.4 years of use. So in table 1 here, you can see the primary surgeries that these patients required. So 112 of them required enterocystoplasty, 10 simple cystectomies, 1 cystoprostatectomy, and 1 radical cystectomy. The numbers here are going to add up to more than 193 because some of the patients either had to be reoperated on or had combined procedures. And then in table 2, we have the results here. So initial success rate, it was in 78% of patients, or 88 of the 110. And the reoperation rate was 17%. 19 of these patients required reoperation. However, major postoperative complications did occur in 56% of these patients. And 11% of the patients who underwent reconstructive lower urinary tract surgery were found to develop de novo ureteral obstruction after surgery. 24% required a reoperation to relieve pain, and 26 then required intermittent catheterization. So why do we care about this? It's so rare. Probably won't ever see it, right? Well, as you are probably aware of, ketamine is kind of having a moment in the medical space. Currently, the only non-anesthetic approved use for ketamine is intranasal esketamine for treatment-resistant depression, a trade name Spravato, which is a 28 milligram nasal spray used for treatment-resistant depression. And this is the treatment like dosing and guidelines from their website. So as you can see, the dosage is pretty low, actually. If you'll remember from Wu et al., the first stage usually began at half a gram weekly, whereas this is 0.05 to 0.08 grams per week. So it's possible that, this isn't a great enough dose to cause ketamine neuropathy. In Spravato's treatment. However, there is a current investigations of ketamine for a myriad of different conditions, including anxiety, depression, PTSD, bipolar disorder, and chronic pain at varying dosages and durations of treatment. So given the rise of the popularity of ketamine, both medically and in the general public, it is possible that we will begin to see this disease more often in the urology practice. And given that it typically affects very young patients and can be extremely morbid, these patients will oftentimes become lifelong urology patients. So it's very important that we can recognize it and treat it promptly, as it is very rapidly progressive. And that's it. Thank you.
All right, thank you for that. Next, we have a true son of Connecticut, born and raised. He did his undergraduate at Yale University, and then he took a long trip to Stony Brook University for medical school. He is dedicated to uplifting marginalized populations, providing humanistic-based care, and determining avenues to improve urological health outcomes within the walls of the hospital and in the surrounding community. Cristofer Zillo is going to present today The Earlier the Better, a discussion on new prostate cancer screening suggestions for Black men. Thank you.
Thank you for that wonderful introduction. So a little bit of ad-libbing. I didn't write all of that, but I appreciate the introduction. So yeah, my title today, good morning, is The Earlier the Better, a discussion on prostate cancer screening suggestions for Black men. So what are the objectives for today? So we're going to talk about current guidelines and recent trends in PSA screening in Black men. We're going to highlight major issues with earlier screening and the studies used to influence guidelines. We're going to discuss the potential root causes for differences in diagnoses and outcomes, and then I'll leave you with some potential future directions so we can address these issues. So before we get started, I wanted to sort of make a statement on race and racialization. So I think it's important to acknowledge the history of race and racialization. These concepts were originally conceptualized as means to divide and establish superiority, significantly influencing science and medicine. Numerous instances of exploitation have occurred throughout our nation's history, often targeting marginalized racial groups and fostering a deep mistrust of medicine. This historical context, combined with social determinants of health, continues to impact healthcare interactions and outcomes today. Of course, understanding this history is crucial for addressing these disparities and working towards a more equitable healthcare system. So with that being said, I wanted to start by talking about prostate cancer by the numbers. So based on data from 2018 to 2022, 12.8% of men will be diagnosed with prostate cancer in their lifetime. In 2021, there was an estimated over 3 million people, 3 million men living with prostate cancer in the United States. And as of 2022, Black men in the United States are more than 1.5 times more likely to be diagnosed with prostate cancer, and they are more than 2 times more likely to die of prostate cancer. So very significant and alarming numbers. And so, of course, naturally, we go to the guidelines, and these are the AUA 2022 early screening guidelines. So the guideline statement 5 essentially says that, if you're Black ancestry, if you have any germline mutations or a strong family history of prostate cancer, you want to start screening these individuals earlier. And that to them is from 40 to 45 years when you start with your baseline PSA screen. And so there was this study in 2021 published in the Journal of the National Cancer Institute that basically looked at a model-based analysis of when we should start prostate cancer screening in Black men. So the slide's a little busy, but bear with me. There were 2 microsimulation models. One was the Fred Hutchinson model, and the other one was this Erasmus Medical Center model. And essentially, they took prostate cancer state transition rates and they calibrated it to SEER data, which, just for the record, around 9% of the patients were Black in that data. And essentially, what they did was that the model reflects a greater risk of disease onset and progression to metastasis before presentation for Black men compared to all other races. And that was essentially what they saw in the SEER data. And then they established this idea of mean lead time, which essentially is the average time by which screening advances detection under a specific screening strategy. So essentially, in English, that means that a longer MLT reduces mortality, but essentially increases overdiagnosis. So you want to kind of balance the two to make the most optimal screening strategy. And so historically, they had this historical calibration of prostate cancer screening, and that's biennial PSAs for ages 50 to 84. And they essentially compared 50 to 84 to 40 to 84, and then this kind of, as you'll see, the sweet spot of 45 to 69. So what were the results? So based on the historical model, Black men actually had a similar NLT and mortality reduction compared to other races. And then you have the comparison of 2 models, 21% to 24% reduction in mortality versus 20 to 24% in the other model. And then there was also a much higher frequency of overdiagnosis. The age ranges there, 75 to 86 men out of 1,000. 58 to 60. And then when they looked at the 40 to 84, the mortality reduction was 29 to 31%, but the overdiagnosis was extremely significant. 112 to 129 men were overdiagnosed per 1,000. And then they essentially argued that the sweet spot was this 45 to 69 age range, in which the mortality reduction was 26 to 29%. And the overdiagnosis, as you see, was essentially halved, 51 to 61% per 1,000. And so here is essentially a very dramatic diagram of, looking at, 950 men dying of other causes with no screening. And then if you don't screen, 50 men in this diagram would die, and then 40 would die under historical screening, which, to mention, also had they calculated so that the biopsy rate was 40%. And then in the age range of 40 to 84, and then with their sweet spot sort of argument of 45 to 69, I think 35%. So what about 2024? These are studies from 2021 and 2022, but really it's much more of the same. So the center of this talk was based on this abstract that came out earlier in April from the Prostate Cancer Foundation. And it was presented at ASCO, and essentially it was a comprehensive literature search. They analyzed 287 studies. They deemed these relevant for forming these recommendations. And they used Prisma to analyze this data. So generally, they had said utilizing mainly 3 randomized control trials, which of course is a level 1 evidence that for all men, PSA screening should begin at 50, end at 74. And these are obviously for average risk men, and this reduced metastasis and prostate cancer related death at 16 and 22 years of follow-up. But really, what we want to talk about is what their recommendations were for Black men. So the best available evidence was from observational and modeling studies, so something to consider. Essentially, they looked at cohort studies, and they suggested that the PSA testing for men should begin in their early 40s, and then modeling studies demonstrate prostate cancer develops 3 to 9 years earlier in Black men. Basically, you can extrapolate from what they were saying, and they extrapolated actually that baseline PSA at 40 to 45 years of age, regular screening until 70 would reduce prostate cancer mortality in Black men with a relative risk reduction of 30% without substantially increasing overdiagnosis, which is really essentially what the model that I had just talked about was saying. So what do we make of this? So I kind of had 3 kind of major issues with these suggestions. And first was lack of inclusion, which we'll talk about. Second is this sort of idea of applying a Band-Aid instead of addressing the underlying causes. Earlier screening, the idea of it being a Band-Aid, and then generally the consequences of earlier screening, which is what I'm going to start talking about now. So earlier screening, not always as beneficial as it seems. So this is sort of a list of ideas from this book called Testing Treatments, and chapter 4 was titled Earlier is Not Necessarily Better, and was certainly the inspiration for my title of this presentation. But screening healthy people is something that you have to take very seriously. You're going from potentially asymptomatic individuals to now individuals with cancer, and there's a whole bunch of considerations and life changes when you make that change from being just a normal person and then a person with a diagnosis. Then you have to remember that screening it's not just a test, but you also have to have an effective management strategy. And then specific for prostate cancer, you could have a whole conversation about it, but PSA screening is not the most specific test. There's a lot of things that can cause an elevated PSA. And then 1 in 5 men with clinically significant cancer will have normal PSAs. And then some people might be bothered about the idea of more men undergoing prostatectomies and having radiation therapy in their 40s, and there's a potential for overtreatment and overdiagnosis. And then obviously with those treatment modalities, there's the quality of life consequences that can come with it. And if you're screening earlier, treating people earlier, some men might have incontinence and erectile dysfunction because of their treatment in their 40s, which is something to consider. And then also different topic, but is low-grade cancer even cancer? It's something to consider too. And so now we'll start talking about this lack of inclusion. So what do I mean by lack of inclusion? So much of the studies that are kind of conducted in this realm really lack demographic representation. So these are a list of 4 of the largest PSA sort of screening studies worldwide. And if you add up all the patients included in these studies, it would add up to around 746,000 patients. And really alarmingly, only 3,375 of these patients identified as Black, which is 0.45%. So really, it's not generalizable, and it's kind of tough to apply these guidelines to the entire population if you're not really studying everyone. So as I'm alluding to, is this lack of inclusion affecting the guidelines? And the answer is yes. So this is a study from Urology from 2023 that essentially was looking at representation in studies used in the NCCN guidelines. So again, another busy slide, I apologize, but essentially they analyzed 547 studies, and then they also examined 7 sections within the NCCN guidelines, which are listed on the screen: risk stratification, bone metastasis, et cetera, et cetera. And so they tried to calculate this target percentage of Black representation. And the way they did it was they looked at the death rate for prostate cancer, which I alluded to in the beginning of this talk, but it was specifically is 2.1 to 1. And then they looked at the percentage of individuals in the United States who identify as Black, which is 13.6%. And then they multiplied the two. So it's essentially their target was 28%, 28.6%. And then just something else they saw was only 32.4% of the studies included racial demographic data. And then, when they looked at the demographic data, only 12.8% of the individuals in these studies are identified as Black. So it didn't really meet their criteria. And so this is just a figure that's, demonstrating pretty dramatically the amount of representation in these studies. And that dashed line is the target for the blue line, and it definitely fell short. So we talked about lack of inclusion. Let's talk about the idea of a Band-Aid. So does lowering the screening age actually address sort of the underlying causes? And you can argue that the underlying causes are under screening and under treatment. So it kind of alluded to the under screening portion of it. There's another sort of like a survey study, Roberts et al. In 2018 in Journal of Nursing. Basically, I think less than 50%, around 49% of Black women said that they had ever gotten to PSA. So, prostate cancer screening is lower among Black men, despite having higher rates of diagnosis and death. And, you can talk for ages about, is it access to care? Is it health literacy? Is it mistrust in medicine? You've had multiple instances of really terrible exploitation of, Black individuals in this country, the Tuskegee syphilis experiment, J. Marion Sims, who's, considered the father of gynecology. I mean, there's, many, many more, too many to list, really. And then also the idea that Black men are being undertreated. So there was a study, Moses et al. In 2017, and they found that Black and Hispanic men are less likely to receive definitive treatment for prostate cancer. And they also saw that the odds of receiving definitive treatment worsened with increasing risk category of prostate cancer. So that's also quite an alarming finding. And then also this Hain et al. Study in 2011, they saw that pelvic lymph node dissection rates were lower in Black men compared to white men, specifically in high-risk disease. So I think if you, instead of dropping the screening criteria or the age at screening, doesn't necessarily address these two basic potential causes. So here is a JAMA Oncology article from 2019, which we'll get into, but basically it was a really large comprehensive study analyzing the association of race with outcomes in non-metastatic prostate cancer. So they combine a lot of data. They use the SEER data, they use the VA data, that's very famous, and then 4 pooled NCI clinical trials. So they had a really robust patient population that they were looking at. The outcomes were prostate cancer specific mortality and then other cause mortality. And then they use this IPW inverse probability weighting to adjust for demographic cancer treatment-related baseline differences. And so they found after IPW adjustment that Black race was associated with only a 0.5 increase in prostate cancer specific mortality at, that should say 10 years, at 10 years after diagnosis. So essentially what they were saying is when you control for non-biological differences, such as access to care, standardized treatment, Black race was not necessarily associated with prostate cancer specific mortality. And so, there's 2 key takeaways from this. One is, the study does not support the idea that there is a biological genetic component in relation to these disparities, but also you could argue that it's saying, improving access to care and standardizing treatment can essentially solve the differences that we're seeing. So to summarize, Black men are disproportionately diagnosed with and more often die from prostate cancer. Black race is associated with high risk for prostate cancer, obviously, and current guidelines suggest screening Black men in their early 40s to around the age of 45 or so. Earlier screening is not always better. Obviously, we must weigh the risks and benefits, and much of the data to support earlier screening is not generalized, as I sort of alluded to before. And then you could argue also that earlier screening does not necessarily address the main potential causes for differences in diagnosis and outcomes. And essentially addressing this under treatment, under screening could be the potential answer. But really, you can say all this, but then you obviously need to talk about where we can go from here. So here's a list of, ideas that I sort of generated, but, you have to address and acknowledge the role of structural racism and how much that sort of plays in these disparities, especially with the history of our country. And then I think, we need to sort of shift focus to address underlying causes instead of kind of applying this Band-Aid, I suppose. And then, main point is to also rebuild trust. And this is obviously easier said than done. And I think one way also to improve these disparities is to promote health literacy and diversify educational material. So I found this study from the Journal of Urology, and it basically looked at 150 websites and 150 videos. They, after selecting and sorting through them, 81 websites, 120 videos featured on real people, basically talking about prostate cancer and risk for prostate cancer. And they assessed it on reading level, quality of health information, and then also they looked at the perceived race and ethnicity of individuals featured in the content, and then they just if the videos were discussing racial or ethnic disparities. And so this is a really, really nice graphic that they put together, so I wanted to feature it. But essentially, only 37% of the websites, 24% of the videos had perceived Black representation in them. Only 27% of websites and only 17% of videos discuss racial and ethnic disparities. And then there's also the component of Latinx representation, which this talk is not certainly focusing on, but something to keep in mind. And then another quite alarming thing was, according to their criteria, none of the representative content was understandable, actionable, good quality, and at the recommended reading level, which I think is pretty alarming, to be honest with you. And a lot of people get their information on really everything from videos and websites and such. So this is something that I think we could try and target and get better content out there. And also trying to address underlying biases of physicians and other care providers is definitely easier said than done. And then I think promoting conversations about the risk on the front lines. And when I say the front lines, I mean general practitioners and family medicine physicians. A lot of people that are doing front of these PSAs. So I saw this other article in the Journal of Family Medicine from 2022, and they basically did a survey at the CERA of family practitioners. They had a response rate of 32.5%, and they essentially found that only 29.2% of these family practitioners routinely inform Black men of their increased prostate cancer risk. And interestingly enough, physician age less than 40 years was associated with not discussing race during screening conversations. So there's some work to be done in trying to get people to be more comfortable talking about these things. And I think if patients know of their increased risk and know what prostate cancer is while we're screening for it, I think it could definitely pay dividends in terms of our percentages and disparities. And then I think it's also important to try and increase the number of doctors from marginalized groups. That's a whole separate conversation, but representation in medicine is super important. And also can't forget about other marginalized groups, Native American populations, Latinx and whatnot. So those are my references. Wanted to thank you guys for listening and thank you guys for being super welcoming these last few weeks.